Good evening, all. Let me welcome you all to the 22nd edition of the Ophthalmology PG Classroom by Kerala Society of Ophthalmic Surgeons. Today, we have a squint case. Squint case is very unique. Welcome you all to the 22nd. So can you stop the YouTube somewhere? Somebody's YouTube is working. Today, we have a squint case. Squint case is very unique. Welcome you all. So can you stop the YouTube? Yeah, I am hearing an echo of myself being played. That's because somebody has opened a YouTube. Have you closed that? Thank you. So I would like to say that squint is unique because many times it is extremely difficult discussion. But we have for you a very simple, straightforward lateral rectus palsy, which is the very basic squint, in which there are no obliques, there are no horizontal, there are no verticals, there are no torsions, nothing. It is basic, simple horizontal squint. And that is a very simple thing. But the discussion can be complex, as one of the faculty commented. And we have with us Dr. Harsha, who is going to present to us, and Dr. Sija and Dr. Dhanya, who are both assistant professors at Alleppey Medical College, would be our examiners, and they will be joined by our external examiner, Dr. Shailesh GM, who did his MBBS from Mysore University and post-graduation from RP Center. And he did his neuro-ophthalmology, squint and glaucoma from RP Center as a senior resident, and he's senior resident for 3 years. And then he is also a reviewer to many journals, including American Academy, Ophthalmology, etc. And he has published a lot of articles in peer-reviewed journals. He's a favored presenter in a lot of international conferences. Currently, he's working as a senior consultant of neuro-ophthalmology and glaucoma service at Shekhar Nethralaya, Bangalore. And also, he's in charge of the DNB postgraduate program. And he's presently the scientific committee chairman of the Bangalore Ophthalmic Society and South Zone representative to the Glaucoma Society of India. We welcome you, Dr. Shailesh, to take over as our external examiner, and over to Harsha to present this case. Scientific committee chairman of the Bangalore Ophthalmic Society and South Zone representative to the Glaucoma Society.
Thank you, sir. Thank you for nice
introduction. Harsha, can you over to Harsha to present this case?
Thank you, sir. Just before that, there is slight echo. Some echo is happening.
Yeah, that's because somebody has opened the YouTube also along with it. Harsha, can you? If anybody has opened the YouTube, can you please close it?
Yeah. There are two openings.
Yeah, that's because somebody has opened the YouTube also. Can you look at the? Can you look at the?
They have opened in two devices.
Yeah. Okay. Can you look at the?
They have opened in two devices.
Shailesh, is it from you only?
No. I have only a laptop.
In your laptop, the YouTube is not on. No, it is not on. Yeah. All of you, please check your laptop.
Yeah, I will check it also. Definitely, I'll check once.
Shailesh, is it from you only?
No, I don't think so.
Laptop. In your laptop, YouTube is not on.
No.
Yeah. All of you, please check your laptop.
Yeah, I will check it also. Yeah, we'll also check. We always check
may not be in the Google Chrome. Maybe in Microsoft Edge or something other program also. Just see. May not be in the Google Chrome, maybe in Microsoft Edge or something other program also. Just see.
So should I connect my earphones? Will that be a problem?
No, I think you can just continue. Can you share the screen and start?
Yes.
Yeah.
So should I connect my earphones? Will that be a problem?
No, I think you can just continue. Can you share the screen and start? Sailesh, I think it is from your side. Now that you muted, it is stopped.
Is it
Yeah.
coming?
So
Can you hear?
okay, let us move forward. If you mute, it will stop. Right now that you muted, it is stopped.
No, I'm unmuted.
Just mute it once again. So now it is stopped. Now it is stopped. I don't know why. Maybe you could just log off the laptop and log in again or something like that. Or maybe log in the mobile. Some change. I don't know. Maybe log out and log in once again. Okay, can we start, Harsha? Sailesh can make that change.
Okay, sir. Good evening, everyone. I'm Harsha Estas from Government TD Medical College, Alappuzha.
Maybe log out and log in once again. Okay, can we start, Harsha? Sailesh can make that change.
Okay, sir. Good evening, everyone. The patient is a 53-year-old female from Alappuzha who is a housewife, presented with complaints of double vision for 2 weeks duration. Patient was apparently normal 2 weeks back. Then she noticed double vision while waking up in the morning. It was more on looking down and at distance, and she experienced difficulty in walking due to this. It was not present on right gaze. The images were horizontally separated, and the double vision was not present on closing one of the eyes. It was maximum at the onset and was non-progressive. It was continuously present, and there was no history of diurnal variation. The double vision decreased on turning the face towards left side. She consulted a local hospital and was referred to Medical College Hospital, Alappuzha. There was no complaints of pain, no history of any associated diminution of vision, no history of headache, vomiting, neck pain, fever, or recent vaccination, no history of trauma, no history of deviation of angle of mouth, dribbling of saliva, or difficulty in eye closure, and there was no history of weakness of one side of body or limbs, no history of tinnitus, vertigo, fullness in the ear, earache, or hearing loss, no difficulty in swallowing food, and no history of scalp tenderness or jaw claudication. No history of involuntary intubation. No history of tinnitus, vertigo, fullness in the ear, earache, or hearing loss.
Yeah.
No difficulty
Can I stop you here?
swallowing food, and no history of scalp tenderness
Sailesh?
or jaw claudication. No history of involuntary intubation. No history of tinnitus,
We are hearing the echo from your side.
Is it?
Yeah.
So can I log out and log in, sir?
Yeah, please log out and
Log out and log in.
Log out and so Harsha, you are talking about acute diplopia, no?
Yes, sir.
Yeah. So can you go to the previous slide, please? Previous slide. And double vision while waking up in the morning. All right. So that is acute diplopia. Double vision was not present. So what are the causes of diplopia? Can you tell us what are the causes of diplopia? Let's start from there. Yeah.
Okay. Can be due to muscle weakness. Can be due to
This muscle weakness is a very diffuse terminology. Is it quadriceps weakness which can lead to diplopia? So muscle weakness you should not say. You have to be a little more specific about it. Okay. Yeah. Tell me.
It can be due to any pathology in the extraocular muscles.
Okay.
Or at the neuromuscular junction of the extraocular muscle and the nerve, and or the nerve supplying the extraocular muscle, or at the nuclear level of the nerve supplying the same. These are the causes of binocular diplopia.
Okay, I did not ask
Before
you
that,
binocular.
you have to first classify the diplopia, whether it is monocular or binocular.
Or binocular. I just asked diplopia, right?
Monocular causes are any uncorrected refractive error, astigmatism, or corneal opacities, cataract. Then macular pathologies can also cause uniocular diplopia. Iris pathologies like iridodialysis, polychoria, etc. can cause uniocular diplopia.
All right. So how will you differentiate between uniocular and binocular?
We have to ask the patient to close one eye, and whether it is present even with one eye, it is uniocular. And if it is present only when both eyes are open together, it is binocular diplopia.
Okay. So here in this case, you have actually done that, and you asked the patient whether the diplopia was there on closing one eye or not. And when the patient closed one eye, then the diplopia just vanished, right? So
Yes,
this is a binocular diplopia. Sailesh, welcome back. We are just discussing the causes of diplopia. All right. Yeah.
Yeah, one more thing I noticed in our history, you had a very nice elaborate history you took. Did you take it on the first instance itself, like history of loss of micturition, so many other things, or is it the afterthought, or after the examination you took this history? Yeah, this one is a very long list of history that you have taken, negative history, which is really good. But did it occur to you in the initial step only, or how is it?
Symptoms regarding the diplopia and all I asked in the beginning, but some history were asked for after the examination.
Okay, good. So many times you will have to revisit your history taking. Once you pass through the history, some examination, you'll have to go back again, ask 1 or 2 history pointers. That is one. Number 2, when they said, did they say diplopia clear cut, or how did they say diplopia?
She told she has some difficulty in seeing and difficulty in walking, like that.
Okay. Then how did you elicit the diplopia part?
First I showed fingers and asked whether she's seeing it as 1 or 2. Then
No, she never told you 1 or 2, right? In the initial stage only. She told
I did diplopia charting also, sir.
No, that you did it afterwards. No, that means you are biased. Initially, you should know that whether the patient is having a clear-cut diplopia history or what. So only when you know that you asked, okay. What made you to ask for diplopia?
I asked her to close one eye and ask whether it is present even with one eye opened, but it's absent with one eye. It was present.
Yeah, good. Why I'm asking this, because many times the diplopia is a very tricky thing to elicit. Patients will not tell a very clear-cut history of diplopia. They say vague discomfort, they can't see properly on this side, that side, some giddiness, they can't walk properly, and all those things. Especially when you see the eye, if there is no squint at all, still it becomes more confusing for you to whether it is diplopia or not. So in that context, you have to just ask them just to specifically targeted questions, like whether are you seeing 2 things, 2 objects. When you see long distance, many times they may not see diplopia for the near things, they may see diplopia for the far things. So you have to have a targeted questioning, like are you seeing doubling things, or 2 images when you're seeing a near things, or a mobile, or a paper, or a book reading, or when you watch long distance things, do you see diplopia or double thing? That is one thing. Second thing, as you rightly did, that covering one eye is very important. Like if someone clearly comes with doubling or something, ask them to close one eye and they will come to know that, yeah, it is there or it is not there. Yeah, proceed.
Past history, there is no history of similar illness in the past, no history of ocular trauma or surgery in the past. She's a diabetic for 5 years and is taking a tablet twice daily.
What surgery you expect here?
Squint surgery, scleral buckling surgery, course.
Okay.
The diabetic status is controlled and there is no history of hypertension or dyslipidemia or any other systemic illness.
Now, just Arsha, just be slow in your history taking while telling, because each one is important, so that the others, PGs who are listening also will just digest what you are telling. Huh? Okay.
Okay, sir.
She is diabetic for 5 years.
Yes, sir.
Okay. Next.
She has no addiction. No, she takes non-vegetarian diet and sleep and appetite is normal. She has bowel and bladder habits normal.
No addictions means what?
No history of smoking, can chewing.
Then 2 important things you said, missed one. That's why you should elaborate in this situation. Alcohol. It's also important in neuro-ophthalmic cases. Alcohol and psychosis, they're all part of this. Okay. Don't put no addictions. Put a specific like.
Okay.
Next.
Family history, she's a second child of non-consanguineous marriage, and there is a history of diabetes in elder sister. There is no history of blindness in the family.
What blindness you will look for here?
Due to diabetic retinopathy, if she has a strong history of diabetes and diabetic retinopathy, she can also have diabetic retinopathy.
Mm-hmm. History of wearing glasses?
She has no history of wearing glasses.
Or she has not got it checked itself. Many times people
she has no difficulty in seeing anything. This is the first time she was having some difficulty.
In seeing, okay. What is the age? I missed out on the initial.
53 years.
How much? 53?
53, sir.
Okay. Next.
She belongs to a middle class family.
Okay.
Physical examination. She is moderately built and nourished, conscious oriented to place and time. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There are no neurocutaneous markers seen. There is no palpable thyroid gland swelling.
What does it say? Neurocutaneous markers?
Cafalot spot, and freckles, which indicates neurofibromatosis, and adenoma sebaceum, shagreen patches seen in tuberous sclerosis.
For thyroid swelling, what is the inference?
Probably she's, if thyroid orbitopathy can have ophthalmologic presentation, so she's having no thyroid swelling. Probably she's not having thyroid disease.
Okay. Next. Yeah, anyone can ask, ma'am. Just I'm only asking. Anyone can pitch in and ask. Dr. Gopal, Dr. Shaiba, ma'am, Dr. Danya, ma'am.
Yeah, yes.
You continue, Sailesh, no problem. It's okay.
Vitals pulse rate is 68 per minute with a normal rhythm, normal volume. And
no, before that, Harsha, from the history, all right? From the history, what is our probable diagnosis, bar differential diagnosis?
She's a diabetic and she's having diplopia, symptoms of diplopia, which is more for far than near, and it is more towards left side.
More for distance and near. More for, what did you say?
Distance than near.
More for distance than near. Okay.
And she's having complaints more towards left side when looking left side. And she's also have complaints of diplopia and looking down gaze. So we are suspecting lateral rectus palsy and have a doubt whether superior oblique is involved.
Okay. So the
superior
first
oblique,
thing
why
that
did you say that?
Sorry, sir.
Superior oblique, why did you say that?
Patient has complaints of walking, difficulty in walking. Probably she's having diplopia on down gaze also.
Walking, any diplopia affects walking or running or sitting, standing. Any diplopia need not be superior oblique. Okay, they have to look down sides.
Okay, what is the significance of you are telling diplopia is more for distance than near?
It is more seen in lateral rectus palsy.
In horizontal, in divergent squints it will be seen, is it?
Yes.
Okay. Why is it seen in divergent squints?
In divergent squints, for seeing distant target, we need divergence. Here, divergence is deficient due to abduction deficit. The patient will be having symptoms.
You can put it the other way around. When you read for near, you will have convergence, and the convergence will oppose the divergent squint. No. Okay. So when you are using your convergence, obviously the divergent squint will reduce. So the diplopia will be more for distance. Okay, that is the significance. Now you said that diplopia is more on looking to the left.
Yes, sir.
Why can you put a little bit more light on that? Which will be the muscles involved? Which could be the muscles involved if you are looking at a muscle paralysis? Obviously, when you have diplopia to one direction, which is more than on the other direction, we are looking at concomitant squint or incomitant squint.
Concomitant squint.
Incomitant squint, which means some of the muscles may be involved. Okay, so which are the muscles involved when the diplopia is more towards looking to the left?
The left lateral rectus could be the cause for deficiency. Palsy can be the cause here.
Harsha, any other muscle?
Only, yeah, any other muscle?
Or rectus in a medial wall fracture, medial rectus can be.
No, sir is asking. The patient is having diplopia when looking towards the left. So which are the muscles that can be? We have not examined the patient. Now you have only the history. So what are the muscles that come to your mind when you have that history?
The right medial rectus.
Yes. So right medial
So
rectus
these two,
and the left lateral rectus.
Lateral rectus.
Okay.
and you in your history, you also told that the diplopia, it is non-progressive. What does that indicate? Is there any clue to the
Being the patient,
non-progressive?
so in ischemic causes, the patient will be having maximum symptoms at the presentation, and gradually it diminishes and can disappear.
It improves over time. Okay. Whereas in other, what are the
Whereas
other
in
causes
other,
where we have a progressive diplopia?
Increase dysplasia and all, the symptoms will be progressively increasing. First, the patient will be having less symptoms, and later increasing and will be maximum.
Okay. And you should know that diplopia, is it fluctuating? Is it more in the morning time or evening time? One is the progression. At the same time, diurnal variations in diplopia
Diurnal
also is important. Now, have you asked about that?
Yes, she has no complaints of diurnal variation.
It is constant throughout the day, like.
Sorry, sir.
It is constant throughout the day. The diplopia part is
Yes,
constant.
sir.
So what I'm asking, did you try to get what I'm trying to ask?
Myasthenia gravis. Symptoms will be less in the morning after a period of rest, and in the evening due to fatigue, the symptoms will be more.
The thyroid orbitopathies, some restrictive squints can cause these light diurnal changes, except for these neurological ones. Okay.
Okay, sir.
So with history, you have this right-sided weakness, right? Right-sided movement restriction.
Sir, left side.
Left-sided movement restriction. So
Yes.
you are targeting the muscles, like in the left eye, what muscles you think of? In the right eye, what muscles you think of?
Left lateral rectus and right medial rectus.
So synergistic ones, muscles. Okay. Then what else you can think of?
It can be due to medial wall fracture, causing the restrictive paralysis of the medial rectus muscle in the left eye.
In the left eye. Okay. But there is no fracture history right here. There is no history of trauma.
No history of trauma.
If it were to be a child, then we could have thought of this, because they don't give proper history. In a child, or some lower fracture or some other issues can be there. But in adult, you can give a good history, so there is no history of trauma here. Okay. Then what else?
Other Duane's retraction syndrome, Mobius syndrome, infantile, not appropriate for age.
You are telling a differential diagnosis already.
Yes.
Okay. So we will come to the photograph, then only we'll come to the differential diagnosis part. Here is just a broad outline of what all muscles you will think of here, and when there is restriction of left-sided abduction, you said, no, left gaze movement. Okay.
Yes.
It is a horizontal gaze restriction, what you are telling in the left side.
Yes.
So those muscles which are acting on the left gaze, we have to think of those things, and accordingly you have to further expand your history, like,
Yes.
already you covered a lot of them. Okay. Is there anything else? I can move to the next slide or something. Dr. Gopal?
Harsha, I think you can go to the next slide.
Okay. Coming to the systemic examination, nervous system, higher mental functions were normal. Cranial nerves 2, 3, 4, 6 are dealt with in ocular examination. Cranial nerve 1, there was no anosmia or parospenia. And examination of fifth nerve, motor examination was normal. And sensory, the sensations of a face over the distribution of ophthalmic division, maxillary division, and mandibular division were normal bilaterally. And reflexes regarding the fifth nerve were normal. Then examination of seventh nerve, the wrinkling of neck rate was normal bilaterally. Bell's phenomenon was good in both eyes. Forced eye closure and nasolabial fold were normal both eyes. And deviation of angle of mouth was absent. Blowing of cheek was normal bilaterally. And sensation over anterior two-thirds of tongue, the taste sensation was normal. And there was no hyperacusis. Examination of eighth nerve, with Rini test, air conduction was more than bone conduction bilaterally, and Weber was central. And examination of 9th and 10th nerve, uvula was central, and movement of palate was normal.
So you did the cranial nerve test for this also, 8 now?
Sorry, sir.
You did the test for this actually? Rini test.
Rini and Weber did you actually do?
Which tuning fork you used?
Sir, 124.
Which hertz?
124.
Okay. Good. Next. 9th and 10th.
9th and 10th, uvula was central and movement of palate was 11th nerve, sternocleidomastoid and trapezius had normal power, and 12th nerve, protrusion of tongue had no deviation, and there was no fasciculation seen in the tongue.
Why you want to see all the cranial nerves here?
Because in the course of the sixth nerve, we are suspecting sixth nerve palsy. So in the course of the sixth nerve, there can be associated involvement of seventh nerve at the nuclear level, and at the basilar part there can be, and also at the fascicular part there can be involvement of the fifth nerve and eighth nerve and also the seventh nerve, and at the basilar part there can be involvement of all these nerves, and inside the cavernous sinus there can be again association with these nerves, and there can be involvement of third nerve also. Third nerve.
Basically, you are dealing with the cranial nerve palsy, a neurological case. So it is a mandatory to see all the cranial nerves. Okay, that is one. Then vestibular function and other things you have done.
No, sir.
The postural.
It was not.
Cerebellar test.
Cerebellar test, there are no features of cerebellar. No cerebellar signs were present.
Yeah, you are doing it. Yeah, please
Yes.
go ahead.
Examination of motor system, tone, bulk, power, and reflexes were normal bilaterally. Sensory system was normal bilaterally, and there were no cerebellar signs. There were no signs of meningeal irritation, and skull and spine were normal, and there was no deformity seen.
Okay.
System.
In cerebellar sense, what you wanted to see? What you have done?
Finger nose test, heel knee test.
Okay.
And, look for nystagmus. Then pendular knee jerk, slurring of speech, attack gait.
Gait, yeah, good. Next.
Then musculoskeletal system, cardiovascular system, respiratory system, and gastrointestinal system were normal. Ear, nose, and throat were also normal. Coming to the ocular examination, there was a face turn to left. There were no facial asymmetry. On Hirschberg test, there was 20-degree esotropia in left eye. And on covering the right eye, left eye takes a fixation. And on uncovering the right eye was refixing. Secondary deviation was more than primary deviation. And this was confirmed with prism bar cover test done in all cardinal positions of case. It's not audible, sir.
I think you're muted.
Yeah, how did you do the cover test here?
Cover test using an occluder. Patient was corrected for the ocular posture, the head posture.
Yeah, first thing is see that the head
She was
posture is
seated.
corrected. Yeah, head should
Then
be
using
aligned
an
properly.
occluder.
Mhm. Yeah, go ahead.
Okay.
Yeah, continue. No. How do you do the cover test, Harsh? Continue.
Yeah.
Then a target was given, and the patient was asked to fix at the target.
Target is what target?
And for it was shown.
Pen, huh? Okay, if you want to measure the deviation, how do you do it?
Sir, prism bar cover test has to be done to measure.
Correct. Prism bar cover test. But what should be the target? What will the patient look at?
For distance, the vision chart can be given. For near a target like pen or.
Yeah, so distance you have to have that Snellen chart or whatever chart that you have. Number one. Number two, this is for Hirschberg part you are talking. It's okay, pen torch or any pointed object. You can get an idea of how much is the Hirschberg on the test. But to quantify, you have to have a proper prism bar test. So primary and secondary deviation for the benefit of the postgraduates. How did you do primary and secondary deviation here?
Using cover and cover test, we can get a.
So in this case, how did you do? What did you do, and what was the values in this case?
For prism with prism bar cover test, I got values secondary deviation 40 prism diopters.
No, you specifically tell on this eye where you put the prism and how you record it, because just telling that will not others may not understand.
Yeah,
in
base in, base out, which eye, like that.
Yeah, in this eye, you just tell how did you do it. It is very important. It's very basic thing. So you have to tell which prism you put and on which eye, and how did you record the primary and how did you record the secondary deviation.
So I placed the prism bar with base in front of the right eye, and I got the value for value of primary deviation, and I kept the prism in front of the left eye with base in, apex towards base out.
Apex out or base in? What is it?
Base out, sir, in both.
Left eye, how did you place
base out?
Base out, yeah. So remember that the direction of the prism, the apex should be pointing towards the
deviation.
So that bottom line, remember. Okay, then putting it in the left eye, what deviation you recorded?
Primary deviation.
The first eye you put in the right eye, what deviation you recorded?
Secondary deviation.
What is primary deviation?
It is the deviation of the paretic eye with normal eye fixing.
Normal eye fixing is primary deviation. Secondary deviation
is the deviation of the sound eye with paretic eye fixing.
Yeah. So it is the paretic muscle or the affected eye that is called secondary deviation. So once you make the affected eye in the primary position and whatever the deviation that you are getting in the normal eye, that is secondary deviation. So when do you say it is incomitant and concomitant squint like here?
You
want to record primary and secondary deviations here?
Because in paretic squint, we expect secondary deviation to be more than primary deviation.
Why is that?
Because it is the Parent's law of bilateral innervation.
Okay.
Increased innervation will be sent to the contralateral synergistic muscle in case of muscle paralysis, resulting in increased deviation.
Okay. Now, I think we have 9 gauges here. No.
You can go to the next slide, Harsh.
Examination of ocular movements. Versions, there was a limitation of left eye in levo version. and ductions were done, and grade 3 limitation of abduction was present in left eye. Intuition was normal bilaterally, and convergence was also normal.
Okay, next.
These are the pictures, but these were taken 2 days after the patient's presentation. By that time, she had decreased symptoms and deviation was less.
So duration was 2 weeks, right?
Yes, sir.
And it was taken 2 days after the first presentation. Okay. So describe this 9 gazes.
She has a -3 limitation of left eye in levo version.
Be very slow and methodical, right? Start from the primary position, the central image.
In primary case, she was having esotropia in the left eye.
In the image, it doesn't look like. Maybe you had 2 days before, you said it has improved. Am I right?
Yes, sir.
Patient is slightly looking towards the left side actually here in this case. There is no clear-cut esotropia here.
Yes.
Okay, yeah, fine, that's okay. Next, other gazes, you just touch upon other gaze.
And elevation and depression is normal. And dextro version is also normal. And levo version, there is -3 restriction.
Madam, be slow, be slow, be slow. You have taken the case, you know everything. The other viewers will not be so fast and so well versed with the case. So go for this right gaze. Levo version, tell what is there in the levo version.
There is only.
Put your cursor on the right eye. Let the people see.
Is it visible, sir?
Yeah, now it is visible. So in right gaze or levo version.
Levo version.
What is there?
There is -2 restriction. Only -2 restriction.
How do you say there is restriction in that picture? From how to explain?
Okay. If the muscle is more than if there is no, it is not crossing the midline, it is -4 restriction. If it crosses 25%.
Asha, here we don't know the actual etiology, whether it's a restrictive or paralytic. So better to use the term limitation.
Okay. So if there is 25% movement, it is -3 limitation. And if there is 50% movement, it is -2 limitation. And if there is only 25% deviation, it is -1 deviation limitation.
What is the other way of looking at the left eye movement? This is duction. We are talking about duction, right?
Okay.
So did you cover the right eye in this case, in this gaze? And see if the left eye moves.
Yes, sir. That was also done, but picture is not.
So that's okay. In the picture, you not have a picture of everything. This is a fine photograph. So in this case, left gaze, there is left eye, there is limitation of movement, right? And at the same time, you may have many times the people will not be fixing properly. So cover the right eye and see if the left eye is taking up fixation. Is it really moving? Okay, incompetent versus competent, right? Okay. So next, other gaze.
Other gaze, the levo elevation and dextro elevation and dextro depression were normal, and levo elevation and levo depression were showing minimal -3 restriction. It is seen as only -2 limitation in these photographs.
Is there any vertical component here?
No, sir. On examination, there were no vertical components.
Okay. Okay, I will come to this question once again in the last once the discussion ends. Okay, next. Any pupillary abnormalities? I think you must have told the pupillary abnormalities. Anything?
No, sir. Pupils
We'll
were
continue with the examination now.
Okay, fine.
Next.
diplopia charting. It showed uncrossed horizontal diplopia more in levo version.
How did you do this charting?
Patient was was seated, and the head posture was corrected. And at 1 meter, slit-shaped light source was shown vertically, and the patient was given
What is the slit source? What is that? Tell what you did.
sorry, sir.
What you did, you tell.
Okay, red-green goggles was given, and with red over the right eye,
Okay.
over the left eye, and she was asked to respond whether she is seeing it as single image or double image, and the color of the images also, and whether there is any separation, and it was shown at 1 meter distance. And in the primary case, she had diplopia, and it was increased towards the left. And the green was seen on the left side, which means it is uncrossed diplopia.
So you should ask them the separation, important. And is there any vertical component, any inclination or obliquity to the images? Two things we have to ask. One is the separation, and the separation which is usually maximum towards the paralytic side. So left gaze, we have got the maximum separation, and they look more horizontal. So there is no vertical component here, but you have to stress the patient, like, whether any vertical or any obliquity, because there can be some involvement of other nerves also. Be careful that head should be in a proper position. There should not be any tilt or so keep the head straight and then perform this one. In doubt, we have to repeat it. Before that, you have to explain the patient properly, because it looks so simple. Many times it becomes difficult for the patient to comprehend, and if you don't understand, then you will have a lot of variations. Okay, yeah, this is a nicely done chart. What is the name of this chart? Any Lancaster or any torch test? See, there are so many gadgets that are used to chart. Okay, just read those things. Okay, next.
Now the ocular examination. Examination of right eye, visual acuity was 612 with the pinhole improving to 6.6. Color vision was normal. Lid and adnexa was normal, and conjunctiva was also normal. Cornea, the size and shape were normal. It was clear, and sensation was normal in all quadrants. Anterior chamber, peripheral anterior chamber depth was vanquished green, and there were no cells of flare. Iris had normal color and pattern. Pupil was 3 millimeter round, and direct consensual and near reflexes were normal, and there was no RAPD. Then lens was clear. The fundus examination of right eye with 90D lens. Media was clear. This was normal in size and shape. Well-defined margins were present, and neuroretinal rim was pink, and cup disc ratio was 0.2 with ISND rule obeyed. Peripapillary area was normal. Vessels had arteriovenous ratio 2:3 with no venous dilatation, looping, or bleeding. There were no arteriolar narrowing. Spontaneous venous pulsation was absent. Macula was normal with foveal reflex present. No retinal thickening was noted. Background fundus had no features of diabetic retinopathy. It was normal.
So this 90D examination, come back. So with 90D, can you pick up all the retinal findings?
No, sir. To see the periphery of the retina, we have to do indirect ophthalmoscopy.
Not only periphery, I think Dr. Gopal is there, retina stalwart. Diabetic retinopathies and all also you tend to miss with only this view. Okay, this is just to tell that the disc and macula and the AV ratio is quite okay. But as a comprehensive examination, you have to have the full view, because in view of the diabetic and hypertensive patient. Okay. Next.
Why did you specifically say about spontaneous venous pulsation here?
Because we are suspecting a sixth nerve palsy. So the presence of papilledema, in early papilledema, the spontaneous venous pulsation can be absent. So sixth nerve palsy is more likely to occur in cases of increased intracranial pressure. So to rule out that.
So here, do you say that there is a raised intracranial pressure?
Even though the spontaneous venous pulsation was absent here, the 20% population of normal population can have absent SVP. So probably this patient is also belonging to that category.
Okay. Continue, Asha.
The examination of left eye, which was with,
Yeah, you can
Yeah, anything abnormal you tell.
summarize. Yeah, any positive findings you can tell.
I was normal with no changes of diabetic retinopathy.
Okay.
Intraocular pressure at 10 a.m. on August 5th, 2022 using Coleman applanation tonometer. It was 16 millimeter mercury in right eye and 18 millimeter mercury in left eye, and differential tonometry using Shayot's tonometer. In the primary gaze, it was 17.3 and 5.5 gram beat was used. In abduction, that is in the left eye, it was 20.6 with weight 5.5 gram beat. And
What is the inference?
It is the changes, differences less than 6 millimeter mercury. So it is not significant. And force reduction test was done in left eye. For abduction, it was negative.
When do you get a positive differential tonometry, Shah?
In restrictive,
what cases? In case of restrictive squint. And FDT, how did you do the FDT in this case? Can you explain the procedure?
The patient was in supine position and local anesthetic drops were applied, and a lid speculum was placed. Then the patient was asked to look towards the roof, and using Shayot's tonometer,
the FDT. I'm asking about the FDT.
Okay. Then using a limbs forceps, the opposite limbus, nasal limbus was limbal conjunctiva was catched, and
which movement you are testing here? Which movement are you testing? Abduction in the left eye.
Towards left, and then the nasal limbal conjunctiva was hold, and I tried to move it towards the left side, and so that means it is negative.
If you are getting a free movement, it is negative. Okay.
You can do it either way, both ways. One is holding with one forceps at the nasal limbus and moving it temporarily, the left eye I'm talking about, or you hold on the vertical quadrant like the eye, then move it together, right and left. So that is one thing. And any other tests you did apart from FDT?
We can do active force generation test.
Was it done?
It was. I tried to do, sir. Did the test.
You know how to do it?
Yes, sir.
How? Can you tell? These two are very important, because for planning your surgical this thing, we need this FDT and FGT, very important. So in FGT, how do you do it? FGT, please tell.
The patient was asked to look in the opposite direction, to look towards the right side, and I hold the temporal limbal conjunctiva, and ask the patient to look towards the left. And the force I felt and a feel of tug was observed. So
yeah, correct. Again, you are telling holding in one direction. So it's always better to use both the hands so that you can feel the from both hands. So hold it in a vertical part on the 9 o'clock and this vertical 6 o'clock meridian, 12 o'clock and 6. then ask the patient to move either right or left. So the tug that you feel is very important. What does it say? The tug says, what does it say?
Means the contraction of the muscle.
Yeah, it is still listening.
What is the inference? What does it say?
Means it is cannot miss. So,
No, I did not hear you, Harsha.
Yeah, there
What
was
was the
a break.
inference?
if I
There was a
Asha, can you repeat? Actually, we don't come in here. What is
it is negative for
Mute.
positive for
breaking.
Suppose you get that tug, what is the inference? And if you don't get that tug, what is the inference?
You're getting that tug means there is the paralytic muscle is having some power. Okay. That is why you are getting that tug feeling when you are holding it. Okay.
Yeah, next one. Come to next slide.
Continue.
retinoscopy done at 66 centimeter with tropicamide. It was +3 diopters in the vertical meridian and +2.25 diopters in horizontal meridian in right eye and +1.75 diopters in vertical meridian left eye, and horizontally it was +1.75 diopters.
Yeah, only right eye had some refractive error, right?
Yes, sir.
Okay, next.
Summary. A 53-year-old diabetic female presented with complaints of double vision on down and left gaze of 2 weeks duration. On examination, there was a face turn towards left with a 20-degree isotropy in left eye, with secondary deviation more than primary deviation. Grade 3 limitation of left eye was present in levo version. The best corrected visual acuity was 6/6 in both eyes, and anterior and posterior segments were normal bilaterally. Differential tonometry and force reduction tests were negative. Coming to diagnosis, acute isolated lateral rectus paresis left eye, and the site of lesion is probably basilar part of abducens nerve, and etiology probably ischemic, and she is having diabetic mellitus also.
Why do you say paresis? Why not palsy?
It is partial limitation of the muscle movement.
When you said it's partial, or just to have a objective way of telling?
She has only, when assessing the ocular movements, it was only grade 3 restriction, -3 restriction.
The eye is coming to the midline. It's very important. The eye is coming to the midline or crossing the midline. That indicates it is not a complete palsy. It is not a paralysis. It is not a palsy, but it is paresis. That is one. So we should also look at whether the eye coming to the center or not. Is it fixing or not? Of course, with effort and all. So that gives a good clue. Then sight. How did you point out the sight?
If it is in the nuclear level, there will be horizontal palsy, horizontal gaze palsy, and also seventh nerve involvement. And in the cavernous sinus also, it is more likely to be multiple cranial nerve involvement. So,
where is the nucleus located here?
So sorry, sir.
Where is the nucleus of sixth nerve?
Where is the nucleus?
It is located in the mid pons.
Pons.
Mid pons.
Pons. Okay, and
at the floor of
fourth ventricle. Okay. Now tell me, what is the uniqueness of this abducens nerve like?
It has a long course in the subarachnoid space, and has 90-degree bends at 2 places. One at the base of skull and the other at the petrous, when it crosses over the petrous tip.
So, petrous tip, what does it indicate? Is there any relevance there?
Because in conditions like petrositis and the malignancy involving the petrous bone, the nerve can be easily involved.
What is false localizing sign?
It is in cases of raised intracranial pressure. The sixth nerve can be damaged with by compressing over the petrous tip. leading to a false impression that the sixth nerve is involved.
Okay, so it's very important. Sixth nerve, you should know the anatomy, its course. It's a quite longest nerve and commonly involved nerve actually. So we should know thoroughly its anatomy and its associated nerves which comes across and moves. So this is the sixth nerve palsy. You thought. What other DDs you can think of?
Other DDs like medial wall fracture, medial wall blowout fracture of the left eye, and thyroid eye disease, syndrome, Duane's retraction syndrome, myasthenia gravis.
Which is the closest to the diagnosis, like differential diagnosis? Which one comes to your mind? Two things, DDs. One is Duane's retraction, okay. Another one is infant esotropias, normally regular esotropias. Many times patient will have esotropia, then get compensated, and then develop these diplopia symptoms. So it could be just an esotropia case, okay, that is one. Number two, how do you differentiate these two, an esotropic case as well as a DRS case, Duane's retraction syndrome, from the sixth nerve palsy?
Okay, in Duane's retraction syndrome, there will be there will not be any deviation in the primary case, whereas in sixth nerve palsy there will be esotropia in the primary case.
No, wrong. So in Duane's retraction there are different types. I think Duane's 1, Duane's 2, and 3. Okay, Duane's 1 there is abduction limitation. Okay, along with that there can be the eye can be in primary position. We also call it as a ESO-Duane's, exoduanes, depending on the overaction of the muscle. So don't think that the eyes are in straight position. So it can have a esotropia in Duane's also, especially type 1 Duane's retraction syndrome. There is limitation of abduction. Okay, abduction, abduction. Here the eye slightly can be in the ESO position. So this will mimic a case of sixth nerve palsy, and they also have head position, abnormal head position. And how do you differentiate in this one from the sixth?
On adduction, there will be shortening of palpebral fissure.
Okay, narrowing of palpebral fissure. Then sometimes there can be globe retraction also. Okay,
Retraction of the globe.
Narrowing of palpebral aperture, retraction of globe are two things. Sometimes there can be upshoot and downshoot also. So these are the three typical. So we have to examine the aperture properly in case of any paralytic squints actually, to rule out any Duane's and other restrictive aspect. Then the other esotropia?
Infantile essential esotropia. There would be associated, there can be associated refractive error. Cross fixation will be present.
See, eye movement will be complete actually. In the primary position, they can have ESO, but once you cover and you check for the duction, okay, once you cover the eye and then see, you'll have a complete movement unless there is no restriction. Okay, that is one. Then other DDs?
Other DDs, myasthenia gravis. There will be waning diplopia more towards evening. And there will be features like fatigability, ice pack test, sleep test, and will be positive. Then Cogan's twitch sign will be positive. Peak sign present, and it will be bilateral involvement, commonly asymmetrical. There can be associated ptosis. It will improve with ice pack test.
Thyroid orbitopathy.
Thyroid orbitopathy. The patient will be having maybe having a history of thyroid illness, and there will be proptosis, lid retraction, lid lag.
Conjunctival findings will be there. Orbital,
pain, pain on eye movements.
Yeah. Now, other thing I want to tell is yeah, proceed to the next one. Next DD, if you have anything in mind. Yeah, any trauma, like you said, in traumatic sixth nerve palsy, how do you find out if it is
which all trauma is important if you have a sixth nerve palsy?
In head injury, base of skull fracture, or patient having intracranial bleed causing raised intracranial tension. There can be papillary edema associated with this, pointing raised intracranial tension.
Okay.
So how
So
do you
base of
test the
skull
restriction?
fracture is very important.
Yeah. How do you check the restriction here?
Sorry, sir.
How do you check for the restriction here?
Movement restriction. The force detection test.
Yeah, FDT is very important here to see if there
And
is
saccadic velocity.
Orbital fractures are important. Trauma, not only head injury, head trauma, orbital fractures. As you already told about the blowout fractures.
That's why taking history is very important. Even a subtle injury, patient can miss and they can manifest later. So any small injury to the eye or a fall or something should be carefully assessed. So DD part almost you are touched upon. The next one, next slide. Almost 8.
MRI brain and orbit was taken, and it showed T2 stir hyperintensity in left lateral rectus, possibly denervation edema according to the report of the radiologist.
Do you investigate all cases of lateral rectus palsy, Harsha?
No, madam. The cases which have age less than 50 years and with no history of any comorbidities like diabetic hypertension, dyslipidemia, and those with multiple cranial nerve involvement, bilateral 6-nerve palsy, papillary edema, and those having pain lasting for more than 2 weeks, and those having no sense of not resolving with 3 months. These can have to be evaluated with imaging, neuroimaging. But this patient, we had a doubt of superior oblique involvement, 4th nerve involvement. So an MRI was taken.
If 4th nerve is involved, you mean to say you take MRI?
The multiple cranial involvement.
See, actually, the opening statement you said is less than 50 years, you have to image.
Yes.
Right? Not necessarily. Yeah. Less than 50 years definitely is one thing. Along with it, as you rightly told, a long list of associated features which will make you to think of any imaging modality. More than 50 years also, what are other things you look for? Imaging, you do it only when there is a long-standing this thing, when it is bilateral, and the other associated conditions or associated cranial nerve palsies. And then what other things you would like to look apart from imaging part? Any blood tests, you directly jumped into MRI?
No, sir. We have to do the basic investigations like blood pressure, then blood sugar levels, and also the blood routine examination with platelet count, ESR, CRP, and all can be done. If we are suspecting conditions like giant cell arthritis, then serology can be done. If we are suspecting conditions like syphilis and all, then if we are having strong suspicion and these history of comorbidities are absent, we can go for neuroimaging. Again, if it is negative, we can go for lumbar puncture.
The first thing is the blood test, simple blood test for diabetes, cholesterol status, thyroid status. Okay, then any vascular components and any infective source, the blood test. So first thing is to go for the blood test. Second step will be your imaging thing. Okay, like MRI, then MRA also, and MR angiography, depending on the suspicious site of involvement. Okay, next. So you finished with this one?
Yes, sir.
Now, how do you manage this case? I will just go in 5 minutes time. Just if I can.
This patient, the symptoms resolved within a week, and she has only minimal movement restriction. So in such cases where we suspected ischemic cause, we have to observe the patient and see whether it is resolving. If it is showing signs of decreased symptoms and signs, we can advise the patient to use occlusion or patching, or prisms can be prescribed till the muscle paralysis is fully resolved. And after 6 to 12 months, we can go for any surgical procedure if any persistent muscle limitation is present.
What do you achieve by doing surgery? After 6 months, you said, why 6 months?
Mostly the ischemic causes will resolve by 6 months. If it is not resolving in 3 months, we have to reevaluate again.
Yeah, usually all these cranial nerve disorders usually tends to settle down or improve by about 4 to 6 months. In some situations, slightly more than that. So wait for 6 months for its recovery and let the eye come to the primary position. Many times you'll be jumping for a surgery, then by 6 months you will relax, then you feel that there is no surgery required. Like you only told, after 2 days, the condition improved, right? The
Yes.
photo has changed. Now the eyeball is coming to the primary position. So we have to carefully evaluate systemically and control all the systemic factors, first priority. Second is make her life comfortable by giving a patching or a Fresnel prisms. Usually after 2 weeks, a small angle prisms can be given, and see that the patient does not go outside alone, because and especially traveling in lift, crossing the road, getting down the stairs and all, there will be a lot of confusion. They tend to trip and fall also, especially old people. So see that they are accompanied all the time with someone. And if any doubt, close one eye or a patch to make their life better. Once they are sitting in a comfortable position, they can remove the patch and sit down. So these things, many times, these things only will help them to improve from control of systemic, close monitoring, because things can evolve. A patient can have a tumor or a infection, ongoing infection in the sinus, cavernous, or any other part. So the patient can deteriorate over a period of 1 week's time or so. So keep a close watch on the patient. Tell them that to report to the eye doctor or a neurologist whenever there is worsening of the symptoms. It's very important. And of course, at a drop of hat, don't go for the investigative modalities like imaging part. Just go for those protocol based, like less than 50 years, multiple cranial nerve injuries, severe pain, restrictive movements, and all those things you may have to image, and in consent with your neurologist, because it sometimes becomes multidisciplinary also. And now coming to your surgical options. So FDT, FGT will help us decide. Like, see, if the FDT, FGT are good, what you will do? 6 months down the line, still there is ESO. What you will do?
If the
Surgery.
If it is a partial limitation of the muscle, we have to do the assess the deviation, and if it is less than 20 prism diopters, we can do plan for medial rectus recession or lateral rectus resection, or both together. And if there is more than 40 prism diopters limitation, we can go for the medial rectus recession and lateral rectus resection in the same eye, and medial rectus recession in the contralateral eye. And if it is complete paralysis, we can go for transposition procedures like Hamilton procedure, Jensen procedures.
What is Hamilton?
It is the split tendon transfer of the
To what?
superior rectus and inferior rectus to the lateral muscle.
Jensen? Jensen
is the, here the muscle is not resected or disinserted. It is dissected and tied half of the lateral half of the superior rectus and lateral half of the inferior rectus is sutured to the
lateral rectus. Affected.
12 millimeter from the limbus.
What is important consideration that you do when handling this kind of vertical rectus transposition?
There is, if we are disinserting, there is high chance for anterior segment ischemia in vertical muscles.
Yeah.
So
whenever you touch more than 2 horizontal muscles or more than 2 muscles, so there is a chance of anterior segment ischemia. So that's why there are a lot of variations. Like we don't disinsert, we'll just take the muscle belly and attach to the lateral rectus. And that's why FGT is very important. If the muscle is dead, then you have to bring the recruitment from the superior and inferior recti. If the muscle is working, that is FGT is positive, the muscles are working, then you might as well do only horizontal recti muscles like less than 40% diopters. You recess maximally the medial rectus and resect the lateral rectus. Many times if it is small angle, and one thing is important, see that you tell the patient that you are doing only for bringing the eye to the primary position. Don't promise. People will think that their lateral rectus movement or abduction movement will also becomes normal, which may not be possible here, because there can be movement, but not to the normal extent. The only thing is you should assure them that they can have a primary position, the eyes may be ortho, and some amount of abduction can be achieved with these kind of surgeries. So with this, I will just try to take a break. I'm just exceeding I have to attend. And Dr. Gopal sir, we can continue. Just take a break.
Thank you very much, Sailesh. That has been a very nice discussion, right from the beginning, right from history through examination. Thank you very much, Sailesh.
Thank you.
He has to attend the
very nice
Bangalore Ophthalmic Society Executive Committee. Thank you very much, Sailesh. Anything more in discussion, Madam? Dhanya Madam and Sija Madam?
I think we have covered from history to the management, we have covered everything. Harsha, any other temporary, you told about some patches and all, any other mode of management that can be given as a temporary measure?
Botulinum toxin injection can be given to the...
where do you give that injection?
The lateral antagonistic muscle, that is medial rectus.
Okay. Then we discussed about FTT, FGT. Any other test we would like to do in a paralytic muscle to in a course of time, not even if not in the acute setting, to know the progress?
Saccadic velocity.
That you have told. Any other test like about Hess charting?
That can be done.
That is important. That is very important. Okay, Hess charting.
So, what is spread of committance? I think for all cases of concomitant squint, later after some time it looked like a committance squint. So what are the sequelae or what are the spread of committance? I think for the benefit of other PGs, you can tell me the steps.
First, there would be underaction of the paratic muscle, and then over of the contralateral synergistic muscle, and then overaction of the...
Why? You can say why also.
The overaction of the contralateral synergist is due to Herring's law, where the bilateral equal innervation goes to the yoke muscle, and the overaction of the ipsilateral antagonist is due to Sherrington's law. Then there is inhibitory paralysis of the contralateral antagonist, which is again due to Herring's and Sherrington's law.
Okay, so that is one of the spread of committance. Then, so what will happen to FDT in due course? Any change? You said FDT is negative, but later can it become positive?
Yes, madam. Due to spread of committance,
what will happen?
Due to contracture.
There can be medial rectus contracture. In that time, we can get a like FDT positive. And saccadic velocity, do you want to describe about it?
It is. It will be slow. Saccadic velocity will be slow in paralytic cases, and whereas in restrictive cases, the velocity will be normal, but it will come to a sudden halt during the movement.
What is saccadic movement and what is pursuit movement, and how do you test each?
Saccadic movements, the pursuits are the slow following movements, and in that case, we will have to show a target and ask the patient to follow the target, and we have to move the target. And saccades means the sudden fixation movement. It is tested by showing two fingers simultaneously and ask the patient to look both alternatingly.
So as you told, there will be inhibitional palsy, and what is the method to relieve it? If you or can you reassess?
We can
there is developing patching the. By patching the paratic eye, the inhibitional palsy can be relieved. In infants, how do you assess this deviation?
We can assess the
What are the
deviation,
methods?
infants by using Krimsky test for measurement.
What is its Krimsky test?
By using prisms, we have to observe the corneal light reflex, and we have to increase the power of the prism till it becomes central.
Okay, it's a corneal reflex test using the prism. What are the midbrain syndrome? No, sorry, syndromes associated with the lateral rectus palsy? Named syndromes.
At the level of Pons, we can have Fowley syndrome, Milliard-Gubler syndrome, and also Raymond syndrome.
Raymond syndromes. Okay.
You said in cavernous sinus involvement, there can be multiple cranial palsies. Okay. So any other thing, pupil, do you want to specifically see anything in pupil?
Horner syndrome, if it is meiotic.
Why Horner's is considered here?
In the cavernous sinus, the sixth nerve is in close association with the synthetic plexus around the internal carotid artery. And if it is involved, there can be Horner syndrome. And the pupil will be meiotic.
So the vascular malformations in the internal
people will
carotid
be in
artery.
mid-dilated position, because third can also be involved and Horner's will also be there. So since they both can be involved, so people can be in a mid-dilated position.
Okay.
I think it was a good discussion. We have covered from history till the management, and I think it is beneficial to all the PGs. So can you wind up the session, sir?
Thank you, Dr. Sija and Dr. Danya. It had been indeed a pleasure to have both of you, and Sailesh, of course. And thank you, Dr. Harsha. I think none of the other postgraduates opened their videos, nor did you ask questions to them. I think we should ask all of them questions as well, because otherwise the presenter always has to sit in the hot seat. I think you presented really well, Harsha. Congratulations to you.
Thank you.
Okay, it had been a nice 1 hour of discussion. Thank you very much for all of those who are hearing. We will be here every Wednesday, 7 p.m. All right. Thank you very much.